check, test, one, T, T, check, one, two, three, four, five, six, seven, check, hey, test, one, T, 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 hello, 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 check, 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 hello, 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 check, 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 hello, hello, check, test, 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 one, one, two, hello, hello. 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 Check. Check. One, two, three, 4, 5, 6, 7, 8, 9, 0. Check.
Very good morning to all of you. On behalf of Team Crescendo 2024, once again we welcome you to the second day of the conference. We shall be starting with topics related to the minerals, pediatric mineral disorders to be more specific. For the two topics, we have Dr. Abhamani Baro from Guwahati and Dr. Saila S. Bhattacharya from Bengaluru. So may I request Dr. Abhamani Baro to discuss pediatric DEXA. So stage is all yours, Dr. Baro.
So a very warm good morning to all of you. At the very outset, I would like to thank the organizing team of Crescendo for giving me this opportunity today to talk on pediatric DEXA, whom to prescribe and how to interpret. So bone health is determined by both non-modifiable factors and modifiable factors. So DEXA is the most commonly used method to assess bone health in pediatric age because it is rapid, it is easily tolerated, non-invasive, highly precise, involves low radiation dose as compared to X-rays as well, and it is relatively more available and affordable. DEXA measures bone mineral content in a given anatomical site. So, but the admonition in pediatric densitometry, we should all remember that children are not simply small adults. So, children are definitely different from adults because pediatric skeleton is constantly changing in size as well as shape. Ossification centers diffuse at different age groups. Chronological age may not reflect the bone age. Onset of puberty has pronounced effect on skeleton. Again, we have to think about radiation safety, reference database, and usually we use Z-score rather than T-score in pediatric BMD. Again, the software must also be able to detect low density bone edges. So why do DEXA in children? To identify individuals at risk for skeletal fragility, determine the magnitude of compromised bone mass in children with established bone fragility, and guide and monitor the treatment. The clinical indications for BMD are primary bone disorders like osteogenesis imperfecta, neuromuscular disorders like cerebral muscular dystrophy, Duchenne muscle dystrophy, cerebral palsy, inflammatory conditions like cystic fibrosis, inflammatory bowel disease, then endocrine disorders like Cushing's syndrome, hyperparathyroidism, etc., hematological conditions after treatment of leukemia and sickle cell anemia, thalassemia, inherited metabolic disorders after solid organ transplantation, monitor treatment of bisphosphonates as well as children who are on chronic glucocorticoid therapy. Now, proximal femur and neck of femur we do not do in children. Why? Because ossification centers they develop at the age of 3 years, but it does not fuse and it is not complete till 18 years of age. Again, it is very difficult to place ROI, that is region of interest, this red color triangle as you have seen. So it is very difficult to put because these are not very clear, difficult. Also because the child will keep moving and positioning is a problem, and it can be done, however, during transition to adulthood, maybe around the age of 16 to 17 to 18 years of age. Terminology used in DEXA: we do not use osteopenia and osteoporosis in pediatric DEXA. We use low bone mass or bone density. It is a preferred term, and we consider this when the aerial BMD is less than -2 Z-score, SD scores. So what are the ideal sites for BMD in children? It is the posterior anterior lumbar spine and total body less head. VFA, that is vertebral fracture assessment, it is done in glucocorticoid induced osteoporosis. Lateral distal femur, it is usually done in cerebral palsy and children who are not mobilizing, immobile, because there is immobility, and we want to know the risk in the fracture of long bones. Proximal femur during transition, as I've already mentioned, and forearm, that is distal 33% radius, when we cannot use the other sides like severe deformity, severe scoliosis, and difficulty in positioning. So forearm becomes an easy procedure. So why head is excluded from the total body? Because skull constitutes a large percentage of the skeleton and it does not respond to physical activity or under other environmental factors. This is forearm BMD in children. So usually the ultradistal forearm, which actually tells us about the trabecular density, it is gaining more and more importance in today's world in terms of pediatrics, and forearm is not subjected to any compression loading. So it is better for monitoring treatment effectiveness during immobility or in children who are immobile like DMD and SMA or cerebral palsy. Forearm is the most common site of fracture during childhood. However, even doing a BMD in forearm site is easy. Again, lateral distal femur, this is reserved only for children like cerebral palsy. So in children who are immobile, like cerebral palsy, Duchenne muscle dystrophy, they are at higher risk of low trauma, long bone fractures, and distal femur fracture, long bone fracture are common in them. So it is easy, and it is also more, has utility in detecting low BMD in children with these conditions. So again, it is easy because positioning is not a problem. Again, we can monitor the effect of changes of weight bearing in non-ambulatory children. So this is a VFA, that is vertebral fracture assessment scan of a child who was a nephrotic syndrome. Actually, she is 17 years old, although she looks like 88-year-old child, and she has been on chronic steroid intake since the age of 3.5 years. So when we look at the VFA, what we see? First of all, we see the vertebral shapes. As you can see on the right hand side, this is Gin and semi-quantitative vertebral fracture grading system. We see whether there is biconcaving, there is loss of vertebral height. At least 20% loss of height suggests that there is some vertebral compression fracture. If there is loss of end plate parallelism, as you can see in the T4, T3, there is end plate parallelism. There is 6-point adjustments are there, and the ends do not look parallel. So there is concavity, biconcavity. Again, end plate interruption and anterior context buckling has to be seen. So just like the previous scan, I have shown 6-point placement. After doing that, we get the anterior, mid and posterior height, and we also get the mid to posterior ratio and anterior to posterior ratio. And any 15% reduction in 2 consecutive BMD scans, if present from baseline, then it suggests there is an incident fracture. So in this child, we found that there was a fracture, vertebral collapse at T6, T9, T10, L3 and L4 vertebra. Now lumbar spine BMD, same girl, we did the lumbar spine BMD. Again, lumbar spine BMD gives us a value of the aerial BMD, which is 2-dimensional. It is not volumetric. For volumetric BMD, we need QCT or we need a BMAD, that is bone mineral apparent density. But then aerial BMD, the positive predictive value is very, very low. It is 24%, and 75% will be wrongly diagnosed to have low bone density using only aerial BMD. So again, although in children with normal height, appropriate for their age, we can use this, but then with short stature, again, we have to go for bone mineral apparent density. So it is like, it considers the vertebra to be a cube, and it is the best predictor of vertebral fracture. TBLH is best for long bone fractures, and it is applicable in children with short stature. So this is the formula where they add the bone mineral content of all the vertebrae divided by the volume of all the vertebrae. So there are a lot of reference data. The one data by the Alphabet study has been given. They have given centile curves different for different machines. Again, there is a BMAD calculator as well available online, where we can select between hologic and lunar, and we get the BMAD record. Now coming to total body BMD, there are a lot of causes of misinterpretation of pediatric DEXA if we do, because there can be chronological age and bone age mismatch. There can be delayed puberty. There could be short stature, height age is less than the chronological age, and there could be bone deformity. So how to correct for age or the lean mass? So first of all, there are various methods, like we can do the HAS method, that is height for age Z-score method. It's a 2-stage approach where we first calculate the child's height for age according to the reference growth chart, and then mathematically adjust the TBLH ABMD with this value. The most commonly used method is the Molgard model. It is a 3-stage approach. We assess the height for age. We see whether actually the bones are short or not, whether this is because of short bones. Secondly, we assess the bone area for height. We see whether the bones are narrow or not. And thirdly, we see the bone mineral content for the bone area, whether the bones are actually light bones and the child has low bone density or not. There is another approach, that is a functional approach, where first we see the lean muscle mass for the height, and then whether the bone mineral content is appropriate for the lean muscle mass or not. So this is a scan. This is a normal child, 17-year-old child scan. As you can see in the BMD machine, we have a osteosis primus machine manufactured by Korea. So in there we get this assessment where there are centiles like from 0 to 100, and any centile value of 5 or less is a cause of cancer. So as you can see, we get the height of age, it was 88, for then BMC for the area is 97, and bone area for height was 87%, but the BMC for the lean body mass was 28%. However, we consider that this is appropriate because it is not less than 5%. So this is by functional approach. This is a scan from another child, a 7-year-old. As you can see, the lean body mass is 79%, but the bone mineral content for the lean mass is just 4%. This suggests that the child has bone mineral content which is less, and the child has low bone density. So what are the elements that we should be included in a DEXA report for a child or adolescent? DEXA machine manufacturer has to be there because references data are dependent on the DEXA manufacturer. Hologic, G Lunar, Norland, Osteosis Primus, these are various machines, and then the reference data, they are not interchangeable. Also, apart from height, weight, and like a source of reference data, we should also mention about the tenor stage or the pubertal stage of the child. BMD definitely differs with ethnicity. As you can see, the Indian data, the pink line, you have seen that lumbar BMD, normal lumbar BMD is comparatively less in Indians as compared to the other Mexicans and as well as other ethnic groups. The best method for reporting a BMD, for spine, we should do a BMAD and a height Z-score adjusted BMAD, or and for total body, we should just adjust using the height Z-score. DEXA osteogenesis imperfecta help us diagnose OI and also monitor treatment response, aid treatment planning, and measure body composition. This is a 7-year-old girl, recurrent fracture in both lower limbs, first fracture at 1 year, and she came with blue sclera. So the BMD Z score for height adjusted was -4. This is another girl. She came to us at 7 years of age, but she was actually taking bisphosphonates right from the age of neonatal age group because she had neonatal fracture. So this child, after having 10 injections of zoledronic acid, as you can see, the Z score is far better. Usually in children with osteogenesis imperfecta who have neonatal fractures, usually their Z scores are worse than -5. But as you can see, because of the effect of 10 injections, we are seeing a better zoledronic acid, better BMD response in this child. So what should be the frequency of doing BMD in OI and how BMD would aid in treatment? Basically, we should do an annual BMD starting from baseline, and then we should monitor annually. If it is -2, below -2, we continue the same dose. Between -2 to 0, we halve the dose, and it is above 0 or above +2, then we can either reduce the dose to 1/4 or we can stop the dose. Now again, DEXA is very important for children who are on chronic glucocorticoid therapy to monitor for glucocorticoid induced osteoporosis. Vertebral fractures are the hallmark of GIO in young children, but then they are frequently asymptomatic. So any child who is on glucocorticoids for more than 3 months with a hydrocortisone equivalent dose of 10 milligram per meter square per day should be, a DEXA scan should be done in this type of children, and annually it has to be monitored. If the steroid continues, if there is persistent risk factors, if there is severe collapse, means vertebral collapse, more than 40% reduction in the height, and in older children, then we start the child on treatment. Treatment should not be based solely on BMD report. Osteoporosis means low BMD plus 2 or more low trauma long bone fractures less than 10 years or 3 or more long bone fractures after 10 years. And with a vertebral crust fracture if present, irrespective of the BMD, it means that the child has secondary osteoporosis. So treatment depends on fractures along with low BMD. So there are various reference data available for depending on the various machines. Again, as I have told you, the reference data are not interchangeable. Different manufacturers give different reference data. Just like I want to show you that if we see the lumbar scans of hologic, lunar and osteosis, the lunar gives the highest reference range. Compared to GE lunar device, the BMD in the osteosis machine were underestimated. So as compared to lunar, it can be underestimated in hologic as well as osteosis primus. So we have to be very careful about what machine you are using, and we should follow up the patient with the same machine. Not that we are doing it hologic today, another 1 year we do in lunar, another 1 year we do it, meaning to say osteosis. So it should be monitored in the same machine. Again, there are a few conversion formulas which can be applied. Safety, radiation safety, again, yes, radiation is very, very less in pediatric BMD. As you can see, a DEXA scan, they have like almost 100 times lower radiation exposure as compared to chest x-ray, as well as 17 times lower radiation than vertebral than lumbar spine. So if you do a VFA have 17 times lower radiation exposure as compared to a plain lateral lumbar x-ray. Now again, radiation safety in children is not same as in adults, because there is something called effective dose equivalent, because children have small body size. Again, it may vary between male and female because of the gonad sensitivity, scan mode, type of mode, and timing of scanning is also important. So as you can see, just to give a brief idea, if we do lumbar spine, the radiation doses are more as compared to total body. If we consider hip scan, it is more in exposure is more in males as compared to females. And we consider the age. Very young age, the exposure is more, the HE is more, but then as we go towards adulthood, the exposure is less. So time interval between two scans should be, minimum gap should be 6 to 12 months, especially 12 months. So we should not do very frequent DEXA scans. To conclude, DEXA is a useful tool to assess bone health in children. BMD interpretation should be, apart from gender and age based, it should be height adjusted, bone size adjusted, and puberty adjusted. Reference ranges are machine specific and not interchangeable. Conversion formula, their present, may be used when available, and decision to treat should be based on fracture rate and should not be solely on the BMD. And BMD be used for monitoring and planning further treatment. Thank you.
Thank you, Baro, for your comprehensive coverage of the topic. Audience might be having some questions for Dr. Baro. So can we invite questions from the audience?
Excellent talk as usual. How does the BFA guide to your treatment in this case? Let's say somebody having a BMD Z-score not less than -2, have some history of fracture, and BFA you can see there are evidences of fracture. How do they guide?
So vertebral fracture, again, when vertebral fracture or VFA we see, so usually that is mainly seen in glucocorticoid induced osteoporosis. So when VFA, according to Ganan's classification, we have mild, moderate, and severe. In mild cases, we do not treat. Moderate cases, again, we have to look at the risk factors. Like again, if their child is going to continue the chronic steroid intake future, then we may consider. But then if it is severe, that is more than 40% collapse is there in the vertebra, irrespective of BMD elsewhere, like total body or other sites. So if severe vertebral collapse, more than 40% collapse is there, then we should start treatment in this child with bisphosphonates.
It again depends on the duration of steroid exposure as well.
Yes, more than 3 months we start monitoring with the equivalent dose of 10 milligram per meter square per day. Again, just I have shown you the case, like the child, the nephrotic syndrome case was on steroids since the age of 3.5 years. So it's been a chronic steroid. So she definitely has vertebral fracture, and because she is a nephrotic syndrome, now she is going into chronic kidney disease because her creatinine is rising. It is 5 now. So in that case, we are planning her on treatment. Because we can't give her bisphosphonates because of high creatinine. Again, teriparatide is an option because she is approaching nearer 18 years of age.
And what about TBS in pediatric age group? Is it not done because of lack of data, or is there any particular concerns, technical issues related to measurement of TBS in children?
So reference data are not much. Trabecular bone scoring usually, I have not found or gone through reference data in regards to trabecular bone score, but yes, there are some studies coming out even in children of trabecular bone score, which we are actually not following and applying to our kids. So it is difficult.
And regarding that follow-up BMD in osteogenesis imperfecta, so if the Z score comes between 0 to -2, rather not not low bone density for age during follow-up. So you have suggested withdrawal of antiresorptives.
No. So in osteogenesis imperfecta, like usually these are primary bone disorders. These are because of genetic like called A1 gene. So in these cases, so if BMD is less than -2, if it is -4, -5, then we continue treatment at a dose that is 0.1 mg per kg per year in 2 divided doses. So, but then if we monitor just the other child I showed you where BMD after 10 injections of zoledronate was -1 Z score. So in that case, maybe we will make it 0.05, half the dose. And between 0 to +2, sometimes on monitoring, they are in the upper hand also. Sometimes mild OI, they will have a BMD of 0 to +2 also. In that case, we may continue at 0.025, 1/4 of the dose. And if there is no fracture, for some time, we may actually plan on physician's discretion. Above +2, we definitely stop zoledronate. So this is how we monitor and we should consider. In osteogenesis imperfecta, it has been seen because it's a primary bone disorder. So the zoledronic acid idea is to continue till the growth is complete. And it has been seen in previous studies that if we stop early this zoledronic acid, then whatever we have built up, again there is yes, sudden yes, loss of bone, and finally they go into again back to more severe bone loss. So it has to be continued.
Nice talk.
Thanks.
So regarding Duchenne's muscular dystrophy, they are on steroids for long, and use of zoledronate. What is your take on it?
So in secondary osteoporosis like Duchenne muscle dystrophy and cerebral palsy, so in these cases they are on steroids, and if we know that yes, they have been on chronic steroid, they have actually exceeded the limit dose, and they are like, we have to follow them up with BMD. So in these children, so if they have a Z score which is -2, less than -2 standard deviation, and if they have severe bone pain because of this, and secondly, like if there is some fracture, low trauma fracture, they are at prone to long bone fracture. So in that case, we can give zoledronate for a period of 1 year to 2 years. So not above that. So yeah, we need to do, but then again, just on low BMD, we do not treat the child with bisphosphonates, because again there has to be a low trauma long bone fracture, and number 2 is if there is severe bone pain because of osteoporosis. So only in two conditions we start treatment. Otherwise, Z score less than -2, we will not start the child on treatment until and unless, and that too we give for a like 1 year duration or 2 year duration, not for extended period, and just monitor.
For conditions like neuromuscular disorders like Duchenne and all, one problem is that, of course, we know that it's mainly because of disuse there is bone mineral density loss. But the other problem is, as there is a loss of muscle mass as well, and DEXA is a study of contrast. So does it affect practically the measurement of DEXA and actual BMD, because it studies the contrast between soft tissue and bone? So does it affect it anyway, or there is some adjustment? I didn't come across any kind of adjustment for this, but any consideration?
So
needed?
like yes, in a cerebral palsy, in Duchenne muscle dystrophy, in all these cases there is muscle mass loss. So if we are doing a total body less head in this type of children, we can adjust to the lean body mass also. So I have seen one of my slides, shown in my slides, that first of all we see whether for the lean mass, whether it is appropriate for the height, and where if the lean mass, for that lean mass, whether the BMC is appropriate or not. So we can do this adjustment. This is known as functional approach, and Crabtree et al. Has actually proposed this, that we can use for lean mass. And in Duchenne muscle dystrophy, cerebral palsy, doing a total body is also difficult because they will have kyphosis, scoliosis. So in those cases, distal femur is being done, and sometimes forearm, ultra distal forearm can also be done in this type of children.
As you said that doing DEXA scan increases this ray exposure. So is there any studies showing the monitoring with bone turnover markers? What's your take on this? The role of bone turnover markers for monitoring?
So yes, we can, we definitely do bone turnover markers, both absorptive as well as formation markers. But then again, this is just for monitoring. So the correlation with BMD, again, when the BMD improves, the bone marker should also improve. So there is, in OI, we do not monitor bone turnover markers, for an example. Even in cerebral palsy and all also, we do not monitor bone turnover markers. No, the guidelines are only based on DEXA scans. Like bone turnover markers may not be as reliable as DEXA scan to monitor and to monitor for basically to decide the treatment about how much to continue and how long to continue.
Thank you once again, Dr. Bharat, for spending time with us. May I request Dr. Bhattacharya to take us through neonatal hypocalcemia.
Good morning, everybody. I thank Team Crescendo, and it's always a pleasure to come to Kolkata, both for personal reasons and for the academic reasons, because I will be always meeting my relatives. When this topic was given to me, I thought what to talk in this hypocalcemia. But once I started doing my slides, I got to know it so much, because this is the first time I am talking on hypocalcemia. So I'll start off with few cases, and then we'll go through the algorithmic approach as requested by the team. So this is a 2-week-old baby boy presented with first episode of seizure. No signs and symptoms of sepsis. Well child, conscious, but irritable and crying all the time. Good weight, height is also normal, head circumference normal, vitals normal. So they called us because they found abnormalities in the investigations. The blood sugar, any child who comes with a seizure, first thing you have to do is rule out hypoglycemia, and this child had a normal blood sugar of 78. And you can see this child had hypocalcemia, both the total and ionized calcium, high ALP, phosphorus normal, magnesium was normal, vitamin D was low, 8.9, albumin was normal, PTH was high. Anybody wants to tell the diagnosis? So you are telling me two diagnoses. Anybody else? I want the junior doctors. Always think simple, do simple things first, okay? So the first somebody told the diagnosis. So whenever you get such cases, especially in the neonatal period, ask the mother's vitamin D, right? We got the vitamin D, which was 8.3. So I think somebody already told the diagnosis, hypocalcemic seizures secondary to vitamin D deficiency, both in the child, and which is reflected because mother also had vitamin D deficiency. These are the most common cases what we see in our day-to-day practice, rather than pseudo-hypo or DiGeorge syndrome. Okay, so how do we define hypocalcemia? Because at different ages, different age of the child, preterm, postterm, there are different values. So you need to know what are the calcium values which you need to know. So early onset is of hypocalcemia is below 72 hours. Late onset hypocalcemia we call when it is child is presenting with hypocalcemia more than 72 hours. And you need to always know the conversion factor, because not all labs give you in milligram per dl. So the conversion is 1 millimole is equivalent to 4 milligram per dl. So when you say hypocalcemia, you will have to have both the total or the ionized calcium. So in the preterm it is less than 7 milligram per dl, and in term it is less than 8 milligram per dl, and the ionized in preterm is less than 4, and in the term is less than 4.8. And in children it's always less than 8.8 is the total, and ionized is less than 4.4. So what is calcium homeostasis? And most of the calcium, we need to know that it is always stored in the skeleton. 99% is stored in the skeleton, and only 1% is in the extracellular fluid, and out of that 40% is bound to albumin. Rest is 10% is to the anions, and the free ionized is in 50%. So if you see here, most of our calcium comes from our diet, and which is absorbed and kept or stored in the bones. It is excreted from the system either by urine or by the feces. To know the etiopathogenesis of any cause of hypocalcemia, we need to know the calcium regulation. So most of the things happen, or calcium is controlled by the parathyroid, bones, intestine, gut, kidney and the gut. And it is also kept in normal status with the help of PTH, vitamin D, and also phosphorus. So whenever you have low calcium, that is hypocalcemia, I have written the two calcium sensing receptor gene which are present in the parathyroid and also in the kidney. So whenever you have a low calcium, then it stimulates the PTH. So there is increase in the PTH release, which acts upon on the bone and the kidney, and at the bone it increases, the PTH increases the bone resorption, whereas in the kidney it upregulates the 1-alpha hydroxylase, which converts vitamin D to 125 vitamin D, which is the active form. This active form of vitamin D acts on the bones, on the kidneys by increasing the renal tubular calcium reabsorption, and also causes phosphaturia. And at the level of the gut, it increases the calcium absorption. Thereby, all these three mechanisms increase the calcium and make it eucalcemia in the body. So once we diagnose with your investigations, or we come across low calcium, we always do a calcium profile. And when we write a calcium profile, the religiously junior doctors just do one calcium. When you say calcium profile, it is never isolated calcium. It has to be a full profile, because you cannot interpret isolated one total calcium for the accurate diagnosis. So you need to do both the total calcium, and facilities are there, ionized calcium. Albumin is very important, I will tell you, because I also told 40% is bound to albumin. Phosphorus, ALP, and magnesium, because if there is low magnesium, you will have problems with the calcium. 25 hydroxy vitamin D levels is important, and the PTH values to see if there is any hypoparathyroidism causing hypocalcemia. And once all these are done, and if you don't come to a diagnosis, you need to also have special tests like creatinine to rule out chronic renal failure or any renal pathology. And in some cases, rare cases, you may have to do a spot urinary calcium creatinine ratio or the 24 hours urinary calcium excretion to get your complete diagnosis. And again, the sampling and sending the sample is also very important. When you talk about calcium or phosphorus sending the sample, you need to make sure you should send it in the fasting, and also you have to send along with the calcium albumin. If you are sending a random calcium in the afternoon or evening along with the phosphorus and also PTH, your values may be abnormal. So try to preferably get it in the morning hours, so fasting, albumin, and if you find that for any reason the albumin is low, you need to get a corrected calcium, and this is the formula. or if you have ionized calcium, that is okay. Next thing, PTH is very important because it is very thermolabile. So when you collect the sample, you have to collect the sample and immediately take it in an ice packet and then transfer it immediately, centrifuge, separate it, and immediately send for assessment. Why I am telling you this is because you saw in the first case, in case that child had vitamin D deficiency with secondary hyperpara, if you don't send the sample properly, that PTH might come normal and you cannot make a diagnosis. So if you get low PTH, you should always think whether it is hypopara or is it falsely collected sample. So it is very important to collect the PTH properly. Next is the phosphorus. Always take it in the fasting state because the food will interfere with the phosphorus levels. Also no tourniquet and no squeezing because it can cause hemolysis and again abnormalities in the spuriously high phosphorus values. Again, you need to know the conversion factor, and always you need to know the age-specific phosphorus values. Because in a neonate, if you get a value of 8, you may think it is high, but it is not high because phosphorus at that age, 8 is normal. So age-specific phosphorus value should be known. So moving on to second case, 6-month-old baby with dengue fever recently came to our hospital, and from an ICU I got a call because the total calcium was 7 milligram and child had ascites, facial puffiness. As usual, the LFT, OTPT were raised and albumin was 2 gram per liter. So what would you do? Very good. So you do a corrected calcium, and with the formula you have got 8.6. For a 6-month-old baby, 8.6 is normal. So you reassure, you don't need to rush to start or do anything extra.
Ma'am, one question. In this sick patient, is it possible, it is rational to check total calcium or ionized calcium? Because there are recent papers, they told that if you check total calcium, it actually not corroborate with the ionized calcium. So always go for ionized calcium in a sick patient. So
Yeah. So that is why in the sick patient you can do albumin and do a corrected calcium, because not all places you will get the facility to do ionized calcium. So it is always 2 ways of doing it and getting an answer. So pseudo-hypocalcemia due to hypoalbuminemia. These things are very much seen because many times you are called in either in nephrotic syndrome, cirrhosis, or cardiac failure, or now the season of dengue fever with this low calcium. So you have to be aware of this condition rather than rushing into treating these children. Next is what is the etiology of hypocalcemia? So we need to know if as I said, it is always the calcium comes from the diet. If there is any malabsorption, chelation, hemolysis, blood transfusion, alkalosis, you can get hypocalcemia. Or if you have any problem with the vitamin D or PTH, you can develop hypocalcemia. So vitamin D, either it is deficiency by the nutrition, or it is because of the inactivation when you are giving anti-epileptics for chronic period, you can have vitamin D deficiency, thereby the calcium deficiency can happen. Also the other causes, as you are all very much aware, it's the vitamin D deficiency rickets or vitamin D dependent rickets or vitamin D resistant rickets 1 and 2, you can have hypocalcemia and chronic renal failure. So the PTH, you can get hypocalcemia due to low PTH for whatever reasons which we will be discussing, or due to pseudo-hypoparathyroidism, kidney disease, or if there is very rare cases where you can get activating calcium sensing receptor gene defect. So what are the signs and symptoms of hypocalcemia? They will not come telling that I have hypocalcemia. So it is like hypoglycemia. Whenever any child has got jitteriness, irritability, convulsions, unexplained seizures, think of hypocalcemia. They can have headache, cardiac defects, they can have cardiomegaly, cataract, increased papilledema, intracranial calcification. Sometimes they would have had this history previously, but when they come to you, you are not able to find the reasons or you are not able to elicit, then you will have to do what we call latent tetany, so where you will do chopsticks or trozesane, which sometimes you would be asked to demonstrate in your examination, where you will tap the in front of the ear and find the twitchings in the facial muscles. And trozesane is you inflate the blood pressure cuff, increase above the systolic blood pressure, and wait for 2 to 3 minutes, and you will find that twitchings or the carpopedal spasm, what we call in the arm, in the hand, sorry. So when you get a child with hypocalcemia, with the two cases which I already mentioned, how do you approach to get a diagnosis? Always, as I said, which we have already mentioned, doing a total or ionized along with that albumin. Never forget to do magnesium, especially in children, and then phosphate and PTH. Why magnesium? Because if there is low magnesium, there will be resistant hypocalcemia. So you need to, and low magnesium can cause functional hypoparathyroidism. So you need to correct the magnesium and recheck the calcium, and then if it is still low, then you start correcting the calcium. If there is magnesium is normal and you have high phosphate, then you will have to do PTH, because when there is low calcium, high phosphate, it's always abnormality of the PTH. So if there is low PTH, the diagnosis would be very simple, as we think, hypoparathyroidism. But if you have a hypoparathyroidism in the neonatal period or in the infancy, you need to rule out if there is any genetic cause. So if child has got any syndromic features, then you'll think of DiGeorge syndrome or GATA3 mutation. But if it is non-syndromic, then you'll have to think of other genetic defects. If you see the same hypoparathyroid picture in an older child, then you will have to think of autoimmune conditions, hypoparathyroidism, APS1, or autoimmune polyendocrinopathy with candidiasis and ectodermal dysplasia. So in these children, you will have to rule out adrenal insufficiency and also check for the screen the parents, siblings, if there is any problem. And if possible and facilities are there, do genetics to find if there is air mutation. And sometimes you can get older children with hypoparathyroidism if it is post-surgical or infiltration due to either tuberculosis, sarcoidosis, or hemochromatosis. If you have high PTH, then you think of pseudo-hypoparathyroidism, where it can be because of GNAS mutation or vitamin D defects or kidney disease. When you find that normal or inappropriately low PTH with hypocalcemia, then you will have to think very, very rare causes. In those conditions, you have to check the urinary calcium creatinine ratio, and if the ratio is more than 0.25, you will think of autosomal dominant hypocalcemia. Again, screen the siblings, parents with the same bone profile and the calcium excretion, and do the genetic test for calcium receptor mutation. If there is mutation problems, then you can get hypocalcemia. Stimulating mutation, then you will have hypocalcemia. Moving on to third case, 11-day-old neonate presented with twitching of hands and feet, birth weight of 3 kg, vitals normal, systemic examination normal, and the values were like this. Any diagnosis? So low calcium, both total and ionized. High ALP, phosphorus is 9.5, 11-day-old baby. Magnesium is normal. Creatinine is normal, so renal conditions are ruled out. Vitamin D is fairly okay, which is 25, and PTH is low. So you have to think of two things. Yes? Hypopara, very good. That is the easy diagnosis because the phosphate is high. So hypopara, right? So when you have a 11-day-old baby with hypopara, as I said, you have to, it can be a simple hypopara, but most commonly if the very young age, you will have to rule out genetic conditions. C for signs and symptoms of Dejart syndrome, send for chromosomal analysis, fish test, simple fish test, which you will get report within a week, where you will find 22q deletion, and the treatment would be with calcium and active vitamin D, which is calcitriol. Mild vitamin D deficiency, that is what we thought. Moving on to case number 4, I don't know how much time I have got. Okay. Okay. 2-year-old baby referred for endocrine opinion. This child has already had one episode of convulsion when the baby was young. EEG was done and child was put on Levipil for that. But they came with when there was second episode of seizure. Birth history was normal, speech delay was there, examination we couldn't find anything, including the blood pressure. And this child, the values were here. Any diagnosis? So low calcium, PTH is inappropriately low for low calcium, right? Albumin is normal, phosphorus is high, and magnesium is low, right? ALP is 238. So this child, when they came for first time, then we had asked for a BARA test, which was normal, and we followed this child treating as a hypopara. But when the child was 4 years, mother complained that child is having poor hearing. Then we did BARA, which showed abnormal results. Same time, then we thought we are missing something in this child. Then when we did an ultrasound, we found that there were some renal abnormalities, and after much convincing, we could get a result of this where there was GATA3 mutation. So any child who starts in the neonatal or early childhood, think of some rare causes and hypoparathyroidism, HDR syndrome. I have 3 patients with HDR, and they are doing very well. So when you have hypoparathyroidism, you have to treat with calcium, active vitamin D, either calcitriol or alpha calcitriol, and always monitor urinary calcium creatinine ratio and do renal ultrasound to make sure you are not over treating and to rule out calcification. So my last case is 8-year-old girl who presented with convulsions, but this child was seeing me during 1 year of age, and then after the COVID, she lost for follow-up. She was seen for hypothyroidism, treated for hypothyroidism, and then around 8 years, she came back with these reports where the calcium was low, phosphorus was high, and PTH was high. What do you want to do? You want to? Face, I couldn't see anything. Anything else you want to see? Face was normal, sorry. You want to see anything else? You did say face, which is very good. Anything else? Yes. The first one is the girl's hand, and the parents had got the sibling who was 6-year-old, and that boy also had similar short metacarpal and metatarsal, right? Have you got the diagnosis? So pseudo-hypoparathyroidism. So siblings, hypothyroidism, hypoparathyroidism, short pseudo-hypoparathyroidism, short metacarpal, metatarsal. You want to make any diagnosis? So I sent for genetics, and you got the GNAS mutation positive, okay? So when this kind of children come to you, they will have hypothyroidism, hypoparathyroid, short stature. You can use growth hormone in this, but these parents lost for follow-up. But these children should be followed up for cataract, skin nodules, intracranial calcification, treatment along with thyroxine. It is the calcium and calcitriol. So,
Ma'am, also this person is TSH resistance likely. That was not subclinical hypothyroidism.
sorry, which one?
You said that the patient was on levothyroxine for hypothyroidism.
Yes.
So it could be that the patient is also TSH resistance rather than the primary hypothyroidism.
Yeah, but they completely lost for follow-up, so we couldn't do anything.
Okay.
Yeah. But when the child presented in the neonatal period, it was a high TSH with low free T4. We thought it was dysharmonogenesis. Treated, then COVID disappeared and they came back only around 6-7 years later. So I think you'll get this in every textbook, so I'm going to skip it. And whenever you have a child who presents to you with acute onset symptomatic hypocalcemia, it is acute management. Always you have to do a long-term management along with calcium and vitamin D supplementation. And the goal is to keep the serum calcium at 8.6 to 10, ionized calcium more than 4.5, and manage the underlying cause. So if the child is admitted in PICU with symptomatic hypocalcemia, rather than giving bolus calcium, always give calcium infusion in a good IV line. So it is 1 to 2 ml per kg of calcium gluconate. Dilute it in 5% dextrose and never do it with Ringer's lactate or a normal saline, and always give it under cardiac monitor. Repeat it, and if the symptoms are better, you can continue and reduce the dose. Infusion rate. If it is not improved, you will have to continue the same. And then over next 48 hours, you can taper it and reduce it 50% and then change over to oral medications. Monitor every day and make sure it is getting better. So as I said, if you are giving bolus, you can develop bradycardia and arrhythmia. So always give it as an infusion. So long-term management, or once you have stabilized the acute management and child is all right and the calcium values have become fairly all right, then you'll have to give a maintenance of 50 to 75 of calcium, elemental calcium. It's actually very difficult to give 4 to 6 divided doses, at least 2 to 3 divided doses. And also, depending on what is the vitamin D, whether it is intact PTH or deficient PTH, you will have to give vitamin D, active vitamin D, or you can give plain cholecalciferol. So to summarize whatever I have spoken till now, the take-home tips, think of hypocalcemia in any child, newborn, infant, or child who presents to you with seizure, tetany, stridor, cardiac failure. If there is a family history of hypocalcemia or very early onset hypocalcemia, always rule out genetic causes along with APS. If you have chronic hypocalcemia, do a proper examination, rule out pseudohypoparathyroidism and very rarely CASR gene mutations. Refractory hypocalcemia, check for magnesium because you can get magnesium malabsorptions which can lead to calcium hypocalcemia. So you have to treat magnesium and then only you start treating calcium. And short metacarpal, metatarsal, cataract, calcification, if you see in examination, think of pseudohypoparathyroidism. Thank you for your patient hearing. And this picture is 3 days back when we went to Masai Mara. It is sunset in Masai Mara. Thank you very much.
Thank you, ma'am. Showing the sunset in the picture. Actually, you did a sunrise for us regarding knowledge in this hall at this early morning. So thank you for that.
I thought already sunrise is over. Sunrise is over. Now it is sunset because you have learnt everything.
Thank you, ma'am.
Thank you.
Thank you. And the hall is now open for questions. And obviously, we'll limit to a few. Any questions? So.
Yes, sir.
Recently, one patient was admitted. Actually, patient is now in the indoor. The patient is a thalassemia major patient, underwent splenectomy few days back, not few months back. Now patient presented with seizure, with severe hypocalcemia. And when we checked, this is actually a primary hypopara, possibly due to depositions of iron in the parathyroid gland. Now, what is the most important challenge regarding management? Initially, patient is under pediatric department and patient was on calcium infusion because patient was very sick. So oral calcium was not started at that time, but with IV calcium followed by oral calcium and active vitamin D, but still it is unable to increase the calcium level above 5. So then they called me from endocrine side and we saw the patient still, there is some features of Vostex and Trajuice was positive. Calcium was around 4.8 to 4.9.
Total.
So this is a patient, and then we think that probably, and the channels are not good, and it is not possible for central line at that time, as per pediatrician's opinion. So what's your opinion regarding that? That we go for some other management modalities, like we have started with the teriparatide twice daily, and patient gradually improved. But just I want to know from your side that what could be the actually, this is the refractory hypocalcemia in a background of thalassemia major.
Yeah, I think in the first, whatever I said, the chelation or the absorption problems, that is what we'll have to think.
Yes.
And if as long as the child is symptomatic, it is always better to give calcium infusion.
Right.
Till it at least comes to 7 or at least the symptoms are gone, because you are telling the signs are still present,
Yes,
or
yes.
trousers. So you will have to continue calcium, and active vitamin D should be continued for longer time, and especially in the neonatal period, not in this, but neonatal period, when children present with hypocalcemia with even vitamin D deficiency, for few days, 3 to 5 days, it is always better you give active vitamin D and then change over to cholecalciferol. In this child, I think you have started and
Yes.
you are doing, I think it is only, we have to wait and watch. Primarily, we are thinking it is all because of the thalassemia, but any surprises can come.
Yes.
So
Right.
I would advise you to do genetic test.
Okay.
also.
Okay. Thank you.
Thank you. Thank you.
Thank you, ma'am. So that was an excellent discussion. And going from the mighty mineral, we are proceeding towards Cushing's. So before proceeding towards Cushing, I have an announcement to make that the certificates of participation are available at the registration counters. I am requesting all the delegates who are available here to kindly collect it from the registration desk at your convenient time. Thank you. So as we proceed towards Cushing's, so we have none other than Professor Tushar Bangar sir, who is the professor and head of KEM Hospital, Mumbai, who will be discussing us regarding the updates in the diagnosis of Cushing syndrome, new versus old. And sir, we are eager to hear from your thoughtful insights.
So, at the outset, thank you to the organizers for this invitation and this opportunity. I'm going to speak on updates in diagnosis of Cushing syndrome, old versus new. So what I'm going to do in next 15-20 minutes is to talk of perils in the diagnosis of Cushing syndrome when you use the older test, and what improvisation we have done with the older test and added on with the new test in the management of patients with Cushing syndrome at St. GS Medical College and KM Hospital over the last 20-25 years is what I'm going to speak on. I'm going to divide my talk in two aspects, looking at the diagnostic aspects of endogenous hypercortisolemia and then looking at the differential diagnosis to reach to the etiology. We know the guidelines tell us very clearly that first we have to prove that there is endogenous hypercortisolemia based on a quantitative test of UFC and qualitative test based on midnight cortisol or late night salivary cortisol, and also do a DEX suppressed test, either ODS or LDDS. But important point in Cushing is that there are various presentations of Cushing's in which we have to apply different tests. If you get a florid Cushing's, it's going to be different test, mild Cushing's, and we have to differentiate between PCOS and metabolic syndrome, and definitely rule out pseudo Cushing syndrome. And let's look at how different tests behave in these different subsets or presentation of Cushing disease. So this is a case who is a case of mild Cushing syndrome. She was diagnosed to have a Cushing's disease and was operated by TSS in Jan 2015. Post-op day 5 cortisol is suppressed, suggesting that the patient is in remission. And then we have a follow-up of the patient for next 4 years, where we follow them up with DEX suppressed cortisol. You can see that the DEX suppressed cortisol is suppressed, but in June 2018, you can see that it's going slightly high. It's not gone to the cutoff of 1.8, where you would see that there's recurrence, and at that juncture, you can see that the midnight cortisol is high and the late night salivary cortisol is also high, but UFC has not gone up. So it tells you that early Cushing's or a mild Cushing's or early recurrences will be picked up by this qualitative test of midnight cortisol and LNSC. Though ODS is showing a trend there, but it has not gone to the cutoff of 1.8, and maybe in 6 months' time it's going to go there. That's a message which tells you that milder cases we have to use qualitative test. As against cases of pseudo-Cushing's where there is hyperactivation of HPA axis, as in this patient who had alcohol exposure as well as mild depression, you can see that cortisol is high, ACTH is high, and the test for quantitative estimation, the UFCs as well as qualitative estimations, MNSC, MNC, LNSC, and even ODS is high, and you cannot differentiate there, but you have to use a stronger stimulus of LDDS to suppress that hyperactive HPA axis, and that's where you can get a suppression there, ruling out that this is pseudo-Cushing's. If you add on a further test of LDDS CRH to it, then it becomes more sensitive and specific as the message goes. So when we talk of the screening test, we know about UFC and midnight cortisol. These are old gold standards because it's a problem doing UFCs, 24-hour collections. There is variability of almost 50%. Mild cases, you're not going to pick up cases of Cushing's there, and 2 or 3 samples have to be done. Same problem with midnight cortisol. It is a sensitive test, but you have to admit the patient, and then that's how it's been looked as gold standards, which is old, and we have shifted, and our tests of choice have shifted to LNSCs and ODS or LDS cortisol, which gives us information in most of the cases. They are very sensitive as well as specificity, which I will be talking about it. So when you look at diagnosis of Cushing syndrome, if you have a florid Cushing, you can do any test and you will be positive. If you look at early Cushing's or a mild Cushing's, then you have to look at LNSC or ODS cortisols. In PCOS or metabolic syndrome, you have to look at ODS or LDDS, and in pseudo Cushing's, LDDS is better test. You add on CRH to it, then it's going to be beneficial. So that's what we are going to talk about. We are going to talk about our experience of LNSCs and ODS. We know the problem with LNSC, with ELISA assays, and now we have the second generation CLIA-based data. We have normative data which is given by Trivandrum group of healthy individuals of late night salivary cortisol, which is published. There is normative data on pregnancies in different trimesters to say that you can use this cutoff to pick up Cushing's, as well as patients who are on, people who are on OC pills. There also is normative data. In fact, the diagnostic performance of LNSC has been proven very clearly by Ames group, where they have shown the cutoff of 0.24 microgram per DL has 95% sensitivity and specificity to rule out Cushing's in these cases. So looking, LNSC is quite good. ODS was always good, but we have had theoretical issues of DEX absorption, metabolism, use in CKD and females on OC pills, where you get false positive test. Overall, this test is very good. It's very sensitive. It's 99% sensitivity, but world over, people used to be worried about specificity of this test, which is around 90%. In our setup, the sensitivity is 99%, but in fact, specificity is also around 97%. We did a study of 1,000 type 2 diabetes patients with moderate to severe diabetes with obesity, and the false positivity was only 2.3 to 3%, stating that this is very good test. It is sensitive as well as specific in ruling out Cushing's and making your diagnosis. It's a very simple test to do. There was no data on ODS cortisol in CKD, so we studied 210 patients with different stages of CKD and devised normative data of CKD in various phases to give a 95th centile to say that above this, please look for Cushing's. Got it published in JES 2024. There is issue of ODS cortisol, especially when females are on OC pills and you are supposed to stop it for 6 weeks according to the guidelines, but it becomes cumbersome and it becomes an issue to stop it. In fact, patients on OC pills, only 25% of the patients will have a false positive test. So this was a study by Mayo Clinic who clearly looked at the ONDST suppressed serum cortisol and free cortisol and tried to compare these two values, and they clearly showed that patients who were on OC pills, the ODS never went more than 5, and more than 5 was a cutoff to pick up patients who had clinical Cushing's and biochemical evidence of Cushing's, suggesting that if Patient is on OC pills, you do ODS, don't have to stop it. If it is less than 5, then it's quite normal. There is theoretical issue of DEX absorption. We don't have any problems with DEX absorption. You don't have to do really dexamethasone assays or to look at it, because we have already shown that. But there could be a case which rarely you can see that this DEX absorption can lead to wrong diagnosis and management. This was a patient who was a case of pituitary incidentaloma, was operated outside based on unsuppressed dexamethasone suppressed cortisol. And the letter went to AIMS, and they thought that the LNC was normal, 24-hour UFC was normal, and did an IV DEXA suppression test which suppressed the cortisol as ACTH after 4 hours, stating that this was an absorption issue which can be rarely seen. Now, we also have our experience of IV dexamethasone suppression test, which we have used in few of these patients. This patient who was admitted with neurologists or neurosurgeons with acute onset apoplexy and was put on IV dexamethasone for the same. They had sent us a call for evaluation, and so we thought that there's some Cushing's-like features there, and we looked for cortisol levels in the face of IV dexamethasone, and the cortisol was high. Even after stabilization, you could prove that the ODS cortisol was on the higher side. We put up our data together of such patients and gave a cutoff of looking or suspecting Cushing's disease with apoplexy in this publication in pituitary. So we've looked at the new gold standards with LNSC and ODS cortisols and advantages and updates with it. LDDS CRH is one of the very good tests which we've been using for so many years now. These patients exemplify what is the importance there. Now, if you look at this girl who has clinically Cushingoid features, the UFC is on the higher side, and the LNSC is also high, but LDDS is suppressed. We know that if you use a strong dose of dexamethasone, mild Cushing's can get suppressed with LDDS, and that's where the dex suppressed CRH comes handy for the use. This patient's cortisol were high, and it turned out to be a microadenoma, which she underwent TS and is doing quite well, as against the other girl who has a similar clinical features. And you can see that UFC is high, cortisol is high, but LDDS was suppressed. We applied the DEXA CRH test, where it was completely flat response, suggesting that this is pseudo-Cushing's, and that's why it is more specific to rule out pseudo-Cushing's as a test there. But CRH is nowadays not available for last 1 year, and hence we have shifted to DEX AVP as a test to rule out pseudo-Cushing's or to pick up Cushing's in these cases. So this was a lady who has come with type 2 diabetes with hypertension. You can see that cortisol is slightly high, LDDS is mildly high, and was referred for our management, where a DEX suppressed vasopressin test clearly showed the cortisol was high. There was a near macroadenoma picture there, and the patient has done good post-surgery over there. So one more addition on diagnostic aspect is the steroid metabolome. The availability of LCMS-based steroid profile in India also is there. So what researchers have done, they are looking at a single test to not only do a biochemical diagnosis of Cushing's, but also to look at differential diagnosis to have a steroid metabolomic signature for adrenal disorders, adenomas, carcinomas, EAS, and Cushing's. So this is our experience where patient with Cushing's on the left side, Cushing's disease, and the right side there's adrenal adenoma. You can see that 11-deoxycortisol and 21-deoxycortisol is high, confirming Cushing's. But your adrenal androgens are increased in pituitary cases, and adrenal androgens are suppressed in adrenal parts. So giving it a single stop test, but you need a lot of research, a lot of data, and standardization for it to be applicable in clinical practice. So LCMS-based assays is a new part to come. So once we know that there is endogenous hypercortisolemia, we next go to the ACTH as a differentiating point. Less than 10 of ACTH is ACTH independent, more than 20 is ACTH dependent, in between is gray area. We have to be aware of problems of ACTH. We all know about pre-analytical issues of ACTH. You have to collect in a cold temperature and immediately centrifuge it. But apart from that, in ACTH independent cases, we are seeing high ACTH levels, falsely high, which change the management, as was seen in this particular case, where a patient with adrenocortical carcinoma was diagnosed to have Cushing disease based on an incidentaloma and was operated without any cure, and was later found to be so-and-so because of the ACTH which was in gray zone. You've used it in a different platform. The platform is Siemens Imulide, which you're not supposed to use for ACTH because you give into false positive test. So we published the data of adrenal Cushing's syndrome, where patients with adrenocortical carcinoma with Cushing's syndrome had elevated ACTH levels from 20 to 60 picogram per ml, and this was all because of doing tests in Siemens immunoid assay. And the moment you shifted to Roche or Toso or Diasorine, then the ACTH would come back to the normal range. And that's why this message goes very clearly that if you're looking at ACTH, please don't use immunoid assay in such cases. When we know that it's ACTH independent, if you look at a single adenoma, you can knock the patient off, knock the adenoma off, and patient is cured. But if you get bilateral adenoma, it becomes an issue. So that's where AVS comes handy to differentiate between which adenoma is secreting, and this is Mayo Clinic data where they have given the cortisol lateralization ratio to decide whether one gland is involved or is bilateral gland which is involved. We have our experience of patient who has come with hypertension, hypokalemia, and was found to have hypercortisolism as well as increased aldosterone, the Cushing's syndrome. There was 2 adenomas which is seen on CT scan, and we were perplexed whether it's which one is secreting cortisol or aldosterone. So we did adrenal venous sampling with DEXA suppression and using androstenedione as a selectivity index. And we could clearly show that the one in the right was secreting aldosterone and one in the left was secreting cortisol, and that's how we could take a right treatment or management for this patient. So once we have discussed about ACTH independent, let's look what are the learning points or the test on ACTH dependency. It's very very well known that 90% of the chance is going to be CD and 10% is going to be ectopic AS, and so any test which you use should have a diagnostic accuracy which is more than the pretest probability of ruling this off. So none of the tests in isolation will be able to differentiate. If you look at MRI at best gives sensitivity of 60%. Even if you do improvisation in the techniques with 3 Tesla or 1 millimeter scans or SPGR, it's best going to be 30 to 40% patients are going to be missed with MRI. In patients with gallium dotated PET CT and CCT of neck to pelvis to look for EAS lesions, even that sensitivity is around 60%, you're going to miss 40% of the lesions, and hence we use dynamic test. But mind you, if you use a single dynamic test, it's not really good. If you look at HDDSD suppression, 20% of the patients with EAS will suppress with it. If you look at CRH stimulation, 20% of patients with ectopic, 15-20% will get stimulated by that, and hence people have suggested, or experts have suggested, to use multiple tests in combination to increase the yield. But the yield is not really good as far as the diagnostic yield is concerned, and hence we use more of IPSS, the CRH stimulated and vasopressin stimulated IPSS to look for the diagnosis. And in fact, the false positivity is in the range of less than 3%, suggesting that this is the best test to look for this particular case. There's a new test which is gallium CRH PET CT. I think Rama was there yesterday, and I'm sure she would have talked about all these tests. This is a very good test. Though it's a single center data, 24 patients data, 100% sensitivity. In fact, patients, 50% of the patients were having lesions less than 0.6 millimeter. And 4 of the patients did not have any lesions on the MRI. And even with that, the sensitivity of this particular scan was good, suggesting that this is there to stay. We need more and more centers to come up with this particular test. I think Desmo-PET is also going to come, and the data is yet to come on that. So as far as the gallium CRH PET CT is turning out to be quite promising for diagnosis of Cushing's disease as such. So we have used IPSS in our cohort, and since the IPSS part was tackled by Dr. Rama, I thought she would be there today, and but I think she finished off the lecture yesterday, and she would have tackled the IPSS details. I'll share whatever we have learned over this period of years of managing CRH stimulated IPSS. So initially we used to do a unstimulated one. There the sensitivity was around 60%, but specificity was 100%. And over the years, then we shifted to CRH stimulated IPS till the recent times. For last 2 or 3 years post-COVID, this CRH was not available to us. We used up our stored samples, but then we had to shift to vasopressin stimulated IPSs. If you compare between CRH stimulated and vasopressin stimulated IPS, they are doing perfectly same and perfectly good job, and we don't miss CRH for IPSs as such now because its almost sensitivity is 95 in either of the two and specificity is 100% in both of these patients groups which we have looked at. But there is differences between these two which we need to understand. That there are some caveats when you're using vasopressin. Like this patient who has come with 18 years of age with resistant hypertension, hypokalemia, biochemically proven to be hypercortisolemic, STH is high, LDDS was unsuppressed. And if you look at the vasopressin stimulated IPSs, the 0 minute, 5 minute, 10 minute and 20 minutes, petrosal sinus and peripheral, there is no gradient at all, suggesting that this is an ectopic case. But if you look at the pink complete column, you can see that the peripheral STH is stimulated to more than 353%, which is like stimulating a Cushing's disease. So when you use CRH, you can get a confusing picture where you could have EAS presentation as well as CD presentation. So the patient was referred to us. We did a CRH stimulated IPSs where there was no gradient between the periphery and the petrosal sinus, and there was no peripheral stimulation, suggesting that, and it turned out to be bronchial carcinoid, so confirming that it is EAS. Hence, what needs to be understood in this case is that if you use vasopressin for a central data, you will get your answers. But vasopressin can stimulate 20 to 30% of peripheral ES tumors, and that's why the peripheral stimulation test will not work. It's the message which goes, and we need to know this caveat in such patients. Important point, when you do IPSs, either by CRH or vasopressin, the timing is the most important. If you do a baseline or if you do 10 minutes, you can get a flat response in a case of Cushing disease. The 2 and 5 minute samples are the most important test timing, at which you will get a chance of hitting being perfectly there, and that's how you can differentiate between these two entities. And 2 and 5 minutes is a sample which has been clearly proven by CRS stimulated as well as vasopressin stimulated data in the literature as well as in our experience. So to summarize, we are looking at newer techniques in diagnosis of Cushing syndrome. We have talked about old gold standards. We have shifted to ODS and LNSC. There is LNSC data, which is the chemiluminescence, which is at a higher version with increased functional sensitivity, doing a good job. There are issues with ODS, but they have been circumvented with normative data and details which are available. We have shifted to LDDS vasopressin and using vasopressin in ruling out pseudo-Cushing's, as well as we have shifted to vasopressin-based CRH. Now it's doing quite well with us. We need to be aware of doing ACTH with the Imulite platform and not do it in that and use other platforms. AVS in bilateral adrenal Cushing's, there is emerging data and we are getting more and more information on it. CRH PET-CT is a new addition which is good for the management, but in IPSS-based vasopressin, it does equally good as CRH, but we need to have a cautious interpretation for the same. So with this, I would like to stop and thank you for your patient hearing.
Thank you, sir. That has been a tremendous experience learning from you. So as we are running late, so I will limit the question to 1 or 2. So any questions? So it's...
Yeah. If you combine 3 Tesla MRI with CRH stimulated gallium PET-CT, do you think you can completely eliminate the need for BIPSS?
So if you get clear-cut answers from these two, if you get complete negative answers in favor of EAS in these 3 tests, then you may generally be avoiding IPSS there. If you get 100% positive answers on that, then also you can get. So if you have multiple tests, then the chances of hitting a particular diagnosis increases. It doesn't become 100%. So studies based on 50 patients, 70 patients are there, which says that if you use all these 3 together, you get either here or positive or negative. But in real world, it becomes very difficult. If somebody asks us that, okay, I see an adenoma, and are you 100% sure? I'm not 100% sure unless I do an IPSS.
And do you use DHEAS index to differentiate between Cushing's disease and adrenal Cushing in a case with dubious ACTH value?
DHEAS, yeah, we definitely use it as a corroborative measure. So, but in lieu of other findings, if STH is down and DHS is also down, then we suggest that it's an adrenal cause.
Thank you.
Thank you.
Nice talk, Dr. Tushar. So how do you measure urine cortisol in your institute, and which cutoff do you take for high UFC?
So we don't use urinary free cortisol as such in our institute that much because of the issues with the sensitivity and all, and being cumbersome test. So we outsource it from a laboratory, and we use 2 to 3 times upper limit of normal as a cutoff, where other tests are showing borderline results, then we may use it. It's a specific test.
Okay.
So if you have definite evidence of hypercortisolism and maybe 2 or 3 times the upper limit of normal, then we would subject the patient to surgery based on that solid data. That's where we want to use it.
And it's done by CLIA?
Yes.
Thank you.
So for the sake of time management, we'll limit the questions to this much. Anybody having a question, sir is here, so I think sir will be better able to answer off stage. So thank you, sir. Sir, it's a great experience learning from you. We do have many questions, but since we are learning late of time, sir. So for the next couple of minutes, we'll be learning about diabetes insipidus from Dr. Shayantan Ray, sir, who is an assistant professor of Department of Endocrinology of All India Institute of Medical Sciences, Bhubaneswar. Thank you, sir.
Thank you for the kind introduction, and grateful to the organizing team for the invitation. Now, the topic is diabetes insipidus. Diabetes word is originated from a Greek word known as siphon, and the word insipidus is from a Latin word that means without taste. And the illustration showing in this slide is from Simmons in 1913, who described Simmons syndrome, showing a destruction of the posterior lobe by a metastasis from a mammary carcinoma causing DI. This will be the flow of presentation. Now, diabetes insipidus is a rare disorder characterized by hypotonic polyuria secondary to either abnormal synthesis, regulation, or renal action of hormone arginine vasopressin. It can manifest at any age, but the age of presentation depends markedly on the etiology. And the most common form of DI is the central diabetes insipidus, with the acquired form being more common than the inherited ones. Coming to the changing of the nomenclature, a position statement from the working group for renaming diabetes insipidus suggested a change of central diabetes insipidus to arginine vasopressin deficiency and nephrogenic diabetes insipidus to arginine vasopressin resistance for more representative of the pathophysiology of the disease. So, a quick normal antidiuretic hormone physiology. On the left panel, it's showing stimulus is increased serum osmolarity or a decreased serum volume, and the normal result of
it, the lesser is your 17 OHP cutoffs. The more is the gestational age, the lesser will be your 17 OHP cutoffs. If you are born premature or if you are born slightly lower birth weight, you have slightly higher cutoffs for 17 OHP. Most of the time, it is best if you obtain a 17 OHP sample after at least 48 hours once the initial stress of childbirth has come down. Or if you have an immediate screening sample, because some labs do a COD 17 OHP, which is actually not the correct procedure, do a repeat sample after 48 hours. Ideally, this should be done by liquid chromatography. The usual CLIA methods are not a very good method of detecting high 17 OHP. Recent studies, which are still not available in India, have looked at precursor to product ratios, 17 OHP versus 11-deoxycortisol ratios. But again, these are expensive, not widely done, and these are not validated in very large studies. The big question is, how many people in this hall actually follow up CAH with 17-hydroxyprogesterone? Can we have a show of hands? How many follow up with 17 OHP monitoring? And what time of the day do you do a 17 OHP? There is actually no specific guideline which tells you that the only cutoff should be a morning 17 OHP. In fact, if you go back a couple of decades, people used to have what is known as 17 OHP day curves. You used to do the 17 OHP every 3 hourly or 4 hourly, look at the entire day curve of 17 OHP, and then decide on the steroid dosing. Because many people actually have an early morning rise in ACTH, and they have a 5 a.m. or a 6 a.m. rise in 17 OHP, which is often missed when you do an early morning. Early morning for most of us means 8 to 9 a.m. In Hyderabad, it would probably be 10 a.m. So basically, this is not a very good method of looking at the cortisol monitoring. Many a time our patients are either over-treated or under-treated, which I'm going to talk about in the metabolotypes. And that is the reason why people have come up with what is known as an androstenedione to testosterone ratio, which looks at the downstream and the upstream metabolites, and also look at progesterone. 17 OHP can be elevated even in well-controlled CH, and sometimes a lot of times we try for a 17 OHP of around 2 or 3, which can actually be an oversuppression. Even in poorly controlled people, DHEAs can be suppressed. A lot of times, even when we look at the total testosterone levels, this can be a concomitant PCOS in these women, especially because of obesity, because of prolonged use of glucocorticoids. And that is the reason people have started progressing more on upstream and downstream metabolites like progesterone, 16-hydroxyprogesterone, 11-beta-hydroxyprogesterone, and one of the most important of which is the 21-deoxycortisol, which I'll tell you later on in the study. But again, the problem with this is most of the commercial labs do not do these tests. Something which has come up very recently in the last 5, it's been around, this data has been around for 20 years, but it's only in the last 3-4 years that people have started looking at it, is something known as the androstenedione to testosterone ratio. Normally in women, the androstenedione to testosterone ratio in a normal woman who neither has PCOS nor has CH is 2:1. Because they have slight production of testosterone from the ovary and a greater amount of production of androstenedione, both from the ovary and predominantly from the adrenal gland. If you got a PCOS as well as a CH, then the androstenedione to testosterone ratio becomes 1:1 because you have increased production of testosterone in PCOS as well as increased production from the downstream metabolites of the androstenedione. If you have uncontrolled CH, then again the ratio goes up to 4:1. This is again an early morning ratio because you have more production of androstenedione from the uncontrolled CH from the adrenal gland. Normally the ratio is 1:5 because predominant androgen produced in the male is testosterone. If you have uncontrolled CH, more amount of androstenedione is produced from the adrenal, so the ratio goes to 1:2. These are all the various ratios which you can decide to see whether your PCOS is well controlled or not very well controlled. A single morning fasting 8 a.m. sample, which is one of the better methods of determining your, looking at your CH control when somebody is on treatment. And in somebody who has CH, especially non-classical CH, and who has infertility, it makes sense to look at the upstream metabolites of 17-OH progesterone, which is the progesterone ratio. Progesterone is almost invariably increased in women who are infertile and who have CH, and this causes a chronic luteal phase. And because of this, implantation and further progress to pregnancy is impaired in these people. And always ensure that your steroid dose is given in such a way that their progesterone is less than 0.6 nanograms per ml. Now coming to the main crux of the talk, this is the most recent guidelines which we have had. The last 15 to 20 years, if you have actually looked at data from Europe, especially the German data, you got something known as urine metabolomics. They do what are known as urine metabolomics and serum metabolomics, which is done via gas chromatography. And recent studies from all the data which they have collected over the past 20 years, they finally defined 3 metabolites of CH, like in the typical Goldilocks zone. Metabotype 1, which is undertreated, metabotype 2, which is well treated, and a metabotype 3, which is overtreated. This was the article which actually gave you the data in 2023. You had the first metabotype, high concentrations of androgen and 17-hydroxyprogesterone precursor steroids. They actually looked at approximately 15 steroids in a metabolomic profile, which was consistent with undertreatment. The usual dose of hydrocortisone which was given in this group was 12.2 plus or minus 1 mg per day, 1 mg per square meter per day. The third metabotype, which was the overtreated, demonstrated marked adrenal suppression with low concentrations of androgen and 17-OHP precursor steroids in urine and low ratio of androgen 17 precursors to THE, which was consistent with overtreatment. This metabotype, again, they had an average steroid dose of approximately 13 plus 0.1 plus or minus 1 mg per meter square per day. The second one, which was in the Goldilocks zone, majority of the patients showed balanced adrenal suppression intermediate between metabotype 1 and metabotype 3. If you actually looked at the data and you looked at the heat map of urinary steroid metabolomic data, the red line is the undertreated one, the green is the right one, the blue one is the overtreated one. And you can look at all this at the bottom line. Each small square in this row represents one patient who was treated, his metabolomics over a period of time which persisted for almost 4 years. If you look at all these data, finally over a period of time, they started getting up to parity in all these patients. They finally ended up in a situation where, but if you look at actually all this data of these patients, almost none of them at any point of time were in perfect treatment. It is that difficult to treat them even with the use of metabolomics. If you look at the treated patients, you will hardly ever see a green small square. If you look at the recent advances in diagnosis, how many of you would actually want to look at a case of CH, look at his face and come to a diagnosis? This is actually being done with artificial intelligence of late. There was one study in 2020 which actually looked at facial morphological patients. When they were looking in California, when they were looking at the faces of people with CH as opposed to people without CH, they realized that people with CH had slightly different features. And that was then when they started coming up with a 3D mapping of the faces of these people. This is a composite of all the patients, female with CH, a male with CH, composite of all the patients who had come to, this was a composite picture of all the patients who had come to the clinic, the control and the normal. And actually, the cursor, we don't have a pointer here. Do. Which one? So if you actually look at the average landmarks, this was the normal person, and you can actually look at the deformation of the nose. The arrow marks actually indicate the deformation of the nose, the deformation of the facial philtrum, and the deformation of the chin. The same thing here. You can actually see the nasal deviation, the deviation of the chin versus somebody with CH, and the facial features. This was what they actually found out in artificial intelligence. And when they did the mapping, the red areas were the areas which were actually more likely to give you a good output on AI facial mapping with regard to what was CH and what was not CH. And this was one other study which looked at a machine learning algorithm to predict late onset 21-hydroxylase in children with premature puberty. So you initially started off with a training set, then you had a replication set. What they actually did in the training set was, they picked up children with CH and compared them with children who did not have a CH. And these were all the metabolites they had studied. This was what they actually found out in the training set. The best results were seen with 21-deoxycorticosterone, 21-deoxycortisol, non-classical CH, premature precocious puberty, 17-hydroxyprogesterone, bone age. These were the 4 most important markers, which were again validated in the second set of patients who were picked up in the second year. And they actually said that the key takeaways were, high number of patients with NCCH actually presented with a cortisol peak below 80 nanograms per ml on ACTH testing, which underlines the fact that even people with NCCH should be given stress dosing. Plasma 21-deoxycorticosterone and 21-desoxycortisol are better markers of CH as opposed to 17-OHP. Maybe a few years down the line, we will have ACTH testing. With or without testing, we will go for these metabolites. This was another study which looked at metabolomics and machine learning to distinguish non-classical CH from PCOS, which is one of the biggest problems we have in our routine day-to-day practice. Again, this was what they actually found. 21-desoxycortisol and desoxycorticosterone did the best because these are markers which are secreted primarily from the adrenal gland. And there is very little testosterone component. If you look at management, these are some of the various newer routines. We are generally tending to go more towards treatment with dexamethasone as the child grows older because hydrocortisone treatment is difficult to maintain. This is actually the day curves you get with each of these molecules. This is what you'd find in a healthy individual. Hydrocortisone, 2 doses, hydrocortisone, 3 doses. This is what you get with prednisolone. And the flattest profile is actually obtained with dexamethasone. Now we've got a few novel therapies. The most important of which are molecules like crinecerfont, which is given twice daily oral. It is an ACTH antagonist. It actually acts at the level of corticotropin releasing factor and blocks ACTH production. So it's administered orally. It cuts down your early morning 17-OHP surge. But the problem with this molecule is, in spite of this, you don't have long-term data, and you will also continue to have to replace people with hydrocortisone. And a lot of times, if you use this molecule, dexamethasone metabolism is increased, so you'll have to switch over to another steroid. This was one study which actually looked at crinecerfont and percentage fall in 17-OHP androstenedione. As the time passes, the percentage fall of these molecules keeps increasing. The longer the weeks on even tildacerfont, the more is the fall. Initially, the fall is very little, then the fall starts increasing. Now, this has come into use. Chronocort, which we've been hearing about Chronocort right from the time we were students. Now, Chronocort has actually come into official use. Oral administration, this is how it works. It has an enteric coat, hydrocortisone layer. It has an immediate release form and a sustained release form. And if you use it once a day, it actually releases enough hydrocortisone early in the morning so that the 5 a.m. or a 6 a.m. peak of 17-OHP is cut down. You have another molecule called FMOD, plenadrin, which is also given once daily, which has been approved in EMA, but it is still not used for CH. It is widely used for adrenal insufficiency, whereas Chronocort was approved in 2021 for CH. We've still not got it. Hydrocortisone pump, which is again widely discussed, but not very practical in the day-to-day setting. And we've got only a single study. We've got CYP17A1 inhibitors, like abiraterone. Again, we've heard a lot about this for the past 6 to 7 years. Effectively controls androgen excess and is very safe. But there is a need for concomitant glucocorticoid therapy, and it can inhibit gonadal sex steroids. So the problem with this is it should be used only in people who do not desire fertility, which eliminates almost 90% of our patients. Newer molecules like navanibib, selective ACAD inhibitors, which reduce the adrenal androgen production, again reduces the dose of glucocorticoids, but this has its limitations. This is what is used in a lot of children, a new molecule called Infocort, which is available in doses of 0.5, 1, 2 mg and 5 mg granules, which can be sprayed over food and given to an infant, but not yet approved in CH because the dosing is not consistent. The last part, people always keep asking us, do we have a final problem solution for CH? The solution which has been proposed of late is something known as genome editing. We've had 3 models: patient-specific cell cultures, 3D structures from a homogenized organ, the so-called 3D printing, and the third one is the mice model, rabbit model, tadpole model, and the zebrafish model. These are the 3 models which are now being extensively studied for gene editing. I'm just finishing. Recently, people have focused more on adenovirus-associated vectors, which have been shown to transduce the adrenal cortex, which is known as gene edition. But the problem with this is the effects are ephemeral. As there is increased cell turnover, within a few years, the effects of these genes do come down. And that is the reason why people are focusing more on something known as gene editing, which corrects pathogenic variants in the genome of the patient cell, including the stem cells, allowing them to produce a corrected progeny, and because this is in the stem cells, this also might not be transmitted to their children. And this is again, if you have read a lot of science fiction, you will read this. CRISPR. The cluster regularly interspaced palindromic repeats, which is what is being used to initiate these changes in gene editing. It has been used extensively in animals, but it has not yet been approved ethically for human research. To conclude, contrary to our usual understanding, 17-OHP cannot be considered a gold standard for monitoring. We should move on. The most practical one right now is androstenedione to testosterone ratio. Steroid metabolomics are widely used in Europe and in parts of US. And we've had a couple of Indian studies, I think, and it's time we started looking at steroid metabolomics. Facial identification, we got only one paper that had a very strong concept of almost 107 patients. Maybe 4 or 5 years down the line, we could just use our smartphone to diagnose CH, or even misdiagnose, mislabel a lot of people as CH. Machine learning and artificial intelligence will help us in doing steroid metabolomics, because the steroid metabolites, as all of us know, are extremely huge in CH. Newer molecules are there. In all probability, within a decade, we are going to get, maybe even less than a decade, we are going to get chronocot. The other molecules are still in the infancy stage. Gene editing is something which is still fit for only science fiction now, but maybe a decade or two down the line, we might start using gene editing in a lot of our children with CH. With this, I end the presentation. If you have any questions, I'll take them.
Thank you, sir. So, as people say, taste success one, tongue wants more. So, reiterating the words from the actor who played Kapil Dev in the movie 83, so we can just re-edit the words that taste a great presentation once, people want it more.
So this time I have passed.
Thank you, sir. So, for your excellent presentation. So, the floor is open for question, if there is any.
How many in the audience have encountered non-classic CH?
How many?
CH. How many? How many? So the prevalence you read in textbook is 1 in 1,000. So we should have how many, with the population of Calcutta, how many non-classic CH should be there? Huge.
Huge.
Why are we not encountering? Why we don't see? None of the wife is gynecologist. No, so they refer all the cases. They're coming, you have huge OPs.
No, actually, I feel a lot of patients who present with hirsutism and not typically fitting in. In fact, it's been my belief for a long period of time that a lot of lean PCOS are actually NCCH.
That's true. We screen them for that.
We screen them with 17-OHP.
So why it doesn't come positive?
Yeah?
So my hypothesis is it doesn't exist in India. It's very rare. It's very rare. It is the Jews which went to US, and wherever they went and how they went, you can tell the history better. You collate the articles, and the prevalence of non-classical CH is because of that. And for some reason, yes, and their migration along the belt through Europe to the US, and US maybe there is a specific population, the New York and the around, not the other part of it. Wherever they have settled.
You got a big theory that you got a huge Beni Israel population in Maharashtra.
Sorry?
You got a huge Beni Israel population in Maharashtra.
So amongst those Jews also there are 4 types. So maybe the other type is with us.
That's a great discussion, indeed.
I think we should reflect more on this. We should read more into this. Yeah.
So, with that remembrance, with that remembrance lingering still in our mind, so we have to proceed to our next discussion, which are the challenges in endocrinology. We must thank our beloved Dr. Sri Nagesh sir with a big round of applause. So thank you, sir. So proceeding towards the next session is, I must introduce Dr. Ayan Roy sir from the All India Institute of Medical Sciences, Kollani, who will be discussing with the resistant prolactinoma, a stepwise approach. So sir, the stage is all yours. So we are eagerly awaiting for your kind deliberation.
Okay, good afternoon all. Thanks for the introduction, and thank you team Crescendo for giving me this opportunity to discuss something on resistance, which of late Kolkata is seeing a lot. So let's start. So I'll be mostly discussing on these four aspects. First, we see what is the definition, like many people define resistance in defined way and what we can take for us. What are the molecular mechanism behind it and what are the different prognostic markers that we can use to see if there is any resistance. Most importantly, whether we can anticipate resistance or not, and then we'll see the management stepwise. So this is a typical case of a 34-year-old recently, which we have encountered in our OPD. Comes with infertility, decreased libidos, classical history, no visual complaints, despite like later on we can see a large tumor. But serum prolactin was quite high, testo was low, as well as LH-FSH was low. He was started on cabergoline 0.25 twice weekly standard approach, then changed to 1 milligram, then 2 milligram per week. But after 1 year, still prolactin is 259 and testo is somewhere around 199. And this is the classical MRI of that patient. If you can see 0, 6, and 1 year. So despite reduction in the tumor volume, there is still, it is persisting with hyperprolactinemia and the hypogonadism is still persisting. So after this, can we say, when can we say that this tumor is resistant to dopamine agonist? The definition has three facets. The first one is obviously the biochemical. That means, why it's not, okay. So the most important thing is the failure to normalize prolactin. Now, why do we take normalization of prolactin instead of saying that reduce prolactin to a sufficient level to achieve ovulation or 50% reduction? Those definitions earlier were also there. The thing is that we do not know at what level of prolactin some patients like gonadal axis is going to be recovered. That is completely individualized. So better to take a definition which can be applied to all, that is normalization of the prolactin levels. Second definition comes as structural. In past, if you see, different studies has taken from 25 to 80% of reduction in the tumor volume, but the current standard of approach is that we must have a 30% reduction in the tumor height or 50% decrease in the coronal surface. This is a pretty simple definition, but very arbitrary, particularly based on a 2006 paper that was published in Clinical Endocrinology, where they have defined that if the person is not responding for 30% in height and 50%, after that, somehow that definition is going on and going on. It's not validated or it's not being utilized by other things. But one thing we have to keep it in mind while dealing with structural thing, that the most important clinical aspects is to see whether we are able to reduce any effect on the optic chiasma. If that is there, then possibly clinically that is a meaningful uptake. But till we get in another definition, 30% reduction in the height and 50% in the volume is good. And there is a therapeutic aspects of the resistance itself. How much dose is required? Since we use cabergoline frequently, not bromocriptine or quinabolide, it's 2 milligram per week. That is the FDA approved maximum dose of cabergoline in a patient of prolactinoma. So as of now, we can take 2. But as we can see later on, different studies have taken different dose and it has gone up to 21 milligram also per week in some studies. So the natural question comes after this, do we have if we start initially very intensive treatment in large prolactinomas, we can see from these PGI studies that there is no role of intensive treatment on with cabergoline on tumor reduction and all those things. Why I am bringing that, I'll come to these studies later on. So if we take these two definitions, one is biochemical, that is the prolactin is going to be normalized, and there will be at least 30% reduction in the tumor diameter in case of macroprolactinoma. What should be the prevalence of DA resistance? How much we can expect? Okay, so the hormonal resistance to cabergoline is roughly around 15 to 20% in macroprolactinoma, but we have to remember that is an overestimation because most of the studies, the dose is not adequate and the timing is not adequate. And if you can see, you have to wait for at least 6 months before you comment that the patient is going to be having resistance. So this is a summary slide of different studies. Pointer. So this is So these are summary slides of different studies that is suggesting how common is the DA resistance. One important aspect is that 5% of microprolactinomas can be DA resistance as well. But if you go for the macroprolactinoma, it's roughly 15 to 20%. But is it this 15 to 20%, is it true resistance? Possibly no. Because if you go on increasing the dose, up to 15% of those who were initially resistant will improve actually, and the finally true resistance will be around 6%. This is one of the largest studies in macroprolactinomas where the true resistance was seen in only 6% of patients. So once we get a DA resistance prolactinoma, we need to understand that there are three aspects of it. Firstly, whether it is refractory, where the major criteria is that prolactin is not controlled and their surgery has to be considered. Second thing, whether it is aggressive, means despite giving cabergoline, there is ongoing proliferation based on MRI. If we see MRI, the size is increasing, so possibly that is an aggressive tumor. And the third one should be carcinoma, where there will be a distant metastasis. So these three things has to be remembered and we need to classify accordingly. So the natural question that comes to our mind is that whether giant prolactinoma will have more DA resistance. Yes, partially true, up to 20 to 25% of giant prolactinomas are based on large registries, can be DA resistance. But again, if we go on increasing dopamine agonist dose, this can be overcome. Now, since we know that 15 to 20% of the DA prolactinomas are going to be resistant, what should be the molecular mechanism? Unless and until we venture into that, the therapies will not be new. So if we see the dopamine receptor, they're classically divided into two parts. First one is D1-like and the second one is D2-like. So this is an important concept where the dopamine receptors are divided into two parts, short and long part. So short part is called D2S and D2L. If you can see the upper end of the image, on your right hand side, that is the long dopamine receptors. There is a particular balance of D2L and D2S in any normal lactotropes. But if any point of time this balance gets disturbed, then there might be ongoing proliferation of the lactotropes. Here we can see there are lots of mechanisms, particularly the changes in the ratio of the D2S versus D2L in the tumor, on the downgrade pathway like beta-arrestin, different types of microRNAs, all of them can play a role in the dopamine resistance. Why this is important to note? Just to see, because lots of therapeutic impact, therapeutic modalities will be coming, particularly involving TGF, beta cycle and all those, which we'll discuss later on, which are important assets while managing DA resistance. And all those drugs usually come from these molecular mechanisms, understanding this molecular mechanism. Can we prognosticate? Like at first instance, whenever we are seeing a patient, can we tell that this is going to be a DA resistance? Yes, some of the patients we can anticipate. If we see the clinical features, male sex is important, young age. Whenever there is a young adolescent or a pediatric age group prolactinoma we are seeing, we need to keep in mind men, but 1 and 4, and also AIP mutation, if it is there or not. But if someone asks me what is the most important factor that is going to tell you that this is going to be invasive, this is going to be resistant, the answer is invasiveness. So the one single most point in MRI, if you find that the prolactinoma is invasive, be ready that it may be a resistant prolactinoma. And also in my clinical practice, particularly here I see lots of cystic prolactinomas in my OPD. They are either partially treated or drug naive. So if you find an invasion or if you find a cystic appearance in the prolactinoma, be careful. And molecular image, obviously, if you have a pretty good pathology support, they can give you the Ki67 leveling, mitotic activity. And if you go for the immunohistochemistry, then either you see how much dopamine D2 receptors are expressed. ER alpha is very important. That's why a low ER alpha expression in the tumor always gives a sign of resistance, which is usually seen in male. There is a recent classification has been given from a French group based on which you can grade the resistance or you can anticipate the resistance. From grade 2A onwards, you can expect that the tumor will be resistant. So apart from clinical, lots of pathological and immunohistochemistry and genetic markers are available to see if you can have a resistance prolactinoma. So now you know that in your hand you have a resistant prolactinoma, you need to treat that patient. So what can be the options while treating a resistance prolactinoma? This is the usual standard management and steps which we can take. The first one will be shift the patient to cabergoline if the patient is on bromocriptine or quinaglide. This is a very established evidence is there. Established evidence is there that cabergoline is much more potent compared to bromocriptine. So definitely you shift it from bromocriptine or quinaglide to cabergoline. That is the first step. What should be the second step if somebody is already on cabergoline? Okay, this is very interesting to see. You increase the dose of the cabergoline stepwise to a maximum tolerable dose. As I have already told you that FDA leveled dose is 2 milligram per week. But if you can see, there are lots of studies. I'll go to the next. Okay, if you can see this study, which I have told you earlier also, the dose has from 2 to 2.5 to 3.5, even up to 7.5 can be gone, and some of the resistance can be overcome. But at least maximum 3.5 milligram per day can be tried in if you are suspecting resistance. Here also you can see the response to the cabergoline therapy is particularly later, but eventually it can happen at a dose of 3 milligram per week up to 84% of patients. So after switching from bromocriptine to cabergoline, the next step will be to dose escalation and to stay at the maximum dose for at least 3 to 6 months to see what is happening. Just don't go on increasing or jumping from dose to dose. That is also important. Okay, so here from the PGI study also we can see if you increase the dose of cabergoline from normal and further in patients who doesn't have a normal prolactin, you can see the tumor reduction is up to additional 31% of tumor reduction can be seen in different types. That means that escalation of cabergoline dose is going to give you results in a good chunk of patients. But there is a caution. Because if you are using a high dose, more than 2 milligram per week cabergoline, the guidelines suggest that you need to check for cardiac valvular disease, particularly the tricuspid valve. So what is the recommendation? You do a baseline echocardiography and then you follow up 2 to 3 years. And it is important to remember that even if somebody has taken a long-term cabergoline in high dose, you need to do a repeat echocardiography even after stopping the cabergoline. Now, can some patients wait, like or dopamine agonist resistance patients? You are thinking prolactin is not normalized, the tumor is still there. Can they wait? Yes. Some patients who are on maximally tolerated cabergoline with a stable prolactin level and the tumor is stable without any visual symptoms, they can also wait. This is particularly true in those type of patients like elderly males or postmenopausal women who have no symptoms. And we should wait for a late response up to 6 months to 1 year on a stable dose in certain patients. But here, if the patient is suffering from hypogonadism, like if the testosterone is low or the fertility is desired, you can go ahead with testosterone treatment or ovulation induction. The step 3 after dose escalation will be surgical debulking. There are certain patients who will not be controlled with highest amount of dopamine agonist, that is cabergoline. They will have a progressive disease, mass effects. Yes, you can think of surgical debulking. Importantly, if we debulk, the disease will not be cured, but the requirement of dopamine cabergoline dosage will be much lower in this group of patients. But recently we had encountered one patient with a very large dopamine agonist resistant prolactinoma where we had to go for an open approach. That means open craniotomy might be required, so a good neurosurgical help is important in this case. Few words about cystic prolactinoma, very important, because cystic prolactinoma will have a prolactin level somewhere between 50 to 150. You might be confused that whether to treat or not. But importantly, cystic prolactinoma responds to dopamine agonist therapy. So a good dose of dopamine agonist should be given for a sufficient amount of time. But it is important to remember to differentiate cystic prolactinoma from RCC, where it will not be responding. Sometimes it is difficult to differentiate cystic prolactinoma versus a Rathke-Klebb cyst. And if we do not have any visual deficit, or we can go for an MRI follow-up in these cystic prolactinoma patients. Sometimes like since D2 receptor are lactotrope, they also have SST receptors. The question comes in our mind that whether SST or agonist like lanreotide, pasireotide, or octreotide are going to be effective or not. Most of the series have shown there is some decrement in the prolactin, but there is no effect on the mass. So possibly they are not going to be effective. Estrogen modulator, again the answer is no. Very small series, some prolactin reduction up to 10-12%, but in the tumor there is no effect. So SSTR and estrogen modulator possibly are not going to be affected. But radiotherapy can be a good choice after surgery if still the patient is having symptoms, large tumors, but we have to tell the patient that the effect is going to take after 2 to 3 years, and other side effects of radiotherapy has to be taken into mind. Temozolomide is possibly one good drug which can use in dopamine agonist resistance patients. However, the data is limited, but if you see the European Society guideline on aggressive pituitary tumor and pituitary carcinoma, they have given temozolomide a pretty good weight there. But the major evidence comes from a single study where there was a 40 cases of lactotrope adenoma, including 25 aggressive ones and 15 were carcinomas. So with temozolomide, we had a 40% achievement of partial response, and the tumor shrinkage was more than 30%. 5% had complete response, and 26% had stable disease. So roughly 75% of aggressive lactotrope adenomas, they responded with temozolomide. But we have to remember this is a cytotoxic agent. You need to talk to your medical oncology colleague before starting this, and you need to monitor so many things. We have good experience with temozolomide back in my earlier institute, where we used to routinely measure the MGMT enzyme, which is also going to give you some suggestion whether the tumor is going to be helpful or not. But the structural, it has to be given in particular cycles and has to be monitored by medical oncologist. But if temozolomide also fails, there are certain optional therapies can be given, particularly ipilimumab, like immune checkpoint inhibitors. If you have facilities, you can go for PRRT and all those, but these all are optionals and very few cases. And certain new drugs like metformin, hydroxychloroquine, ropinirole, all these are some now being routed through, but these are only based on very few cases. So, I mean, in dire situation, we can use. So, based upon available evidences, this is what I could synthesize. You should anticipate resistance, male young patient with paracellular invasion, get some molecular marker from your pathology colleague, and you anticipate the DA resistance. If he or she is not on cabergoline, switch to cabergoline. If on cabergoline, escalate the dose to maximum 3.5 milligram per week. If it is tolerating no side effect, you can go up to 7.5, but remember to monitor cardiovascular effects and others effects like impulsivity and all those things. If there is a response, you follow up on a stable dose. If there is still persistent disease, but sometimes the disease is stable, then also you can follow up. But if even after that also there is tumor progression and compressive symptoms, you go for a debulking surgery plus minus cabergoline after that. Again, if it is after surgery, it is not responding, go for radiotherapy, but you have to counsel the patient that you need to wait for 2 years again. And some aggressive tumors, if you're suspecting it is, aggressive pituitary tumor, go for temozolomide. And if you have a malignancy, again, temozolomide will be a very good options. Again, if persistence even after temozolomide, go for immune checkpoint inhibitors and all other drugs and PRRT. So in summary, DERPs like dopamine agonist resistant prolactinomas are more common in young male patients. The resistance rate varies, but you expect 15 to 20%. True resistance will be low, 6 to 7%. Cabergoline at appropriate dose still holds pretty good. Use surgery and radiation, particularly SRS if available at appropriate conditions. Use temozolomide whenever you are experiencing cabergoline resistance, and it's a good option for aggressive DERPs. And sometimes, even after all this, you can observe the patients, which may be good in particularly elderly patients and postmenopausal women. So I thank you for your patient hearing.
Thank you, sir. So indeed a great pleasure hearing from you that in such a lucid and deliberate manner. So any questions from the audience?
So nice talk, Kayan. So one thing, just asking, in many patients of resistant prolactinoma, we need testosterone supplementation for hypogonadism, persistent hypogonadism. So in that case, we know that it will be converted to estradiol and it can stimulate the prolactin synthesis. So is there was a paper on letrozole. So what is your take on it?
Yeah, so actually, in male patients, if you are thinking that testosterone is going to get converted to estradiol and it is going to stimulate, possibly not. Because the male patients who have more aggressive, already if it is resistant and large aggressive tumor, possibly they are expressing less ER alpha. So possibly estradiol is not going to have any effect in those cases because the tumor, the lactotrope cell by itself is not going to be stimulated by estradiol because of lack of expression of ER alpha. In those cases, I think you can go ahead with testosterone therapy. No need, because the tumor itself characteristically totally different from a sensitive tumor. I think you understand. And the studies, whatever has reported till now, I think some 6 studies are there on letrozole and all, anastrozole, fulvestrant. No good results.
Ayan, just a comment regarding this. You rightly said that usually those are not useful in a patient with testosterone, but in individual cases it is important where you feel that there is a tumor growth after gonadal hormone replacement. Then there is a case series by Mark Molich. So you can use anastrozole, but again, this is maybe a rarity. But in individual case, you may need this. Regarding second point regarding MGMT, as we know that there are other sites also for this temozolomide resistant other than NGMT. So that is not really a sacrosanct. So we can try this even without doing MGMT. So we can try temozolomide.
Yeah, it's not mandatory, but somehow our medical oncology insists.
Yeah, okay.
So any questions from the audience? So if there is none, I have one question, sir, that whenever we give high dose of cabergoline, it is recommended to go for a cardiological screening by echocardiography to see whether there is a right-sided fibrosis. But as we know, the transthoracic echocardiography has got a poor predictive value to determine the right-sided fibrotic events. So what should we do to detect such events?
Yeah, this is a pretty good question. Cardiac valvulopathy due to cabergoline. This is a specific entity actually, CAV, if you can see. So there are two aspects of it. The first aspect of it, does it really occur? Okay, with the regular dose up to 2 milligram, does it really occur? If you see the JCM meta-analysis back in 2019, it suggests yes, it occurs. Odds ratio is roughly 3 if I remember correctly. But in real life, this doesn't happen. Actually, if you see, there are, if cardiac cabergoline associated valvulopathy has 3 important criteria. First one is you have to have a regurgitation. Second one, you should have a restriction of the valve function. Third thing, you should have a fibrosis of the valve function. These 3 criteria has to be met before you tell this is a cabergoline associated valvulopathy. 2 of these criteria you are not going to see by echocardiography. Only regurgitation you are going to see by echocardiography. So echocardiography is a very poor measure. I support you. But again, the same thing, this guideline has come from British Valvular Society along with European Society of Endocrinology. And they have recommended echocardiography only because that is readily available, that's what we can do. And importantly, here again they mention you can only detect regurgitation. So if you detect regurgitation, then only yes. But usually we are not going to do it because someone, if we are treating a resistance prolactinoma with more than 2.5 milligram for long term, then only the risk is coming. Because if you see the cumulative exposure, if it is more than 100, 150, then only the cardiac fibrosis is going to happen. So I agree with you, but this is the recommendation.
Thank you, sir. So it has been a great pleasure to learn from you. So a big round of applause for sir. So thank you, sir. So coming towards almost the last session of our today's academic extravaganza. So calling upon stage our beloved Professor Dr. Kaushik Pandit sir, and who needs no introduction, I believe, but because almost everyone knows him. And President, who has been the President-elect of the Endocrine Society of India. So, thank you, sir. So, the topic we all know, but it is difficult to treat. So, nuances of Graves' disease, easy to diagnose, difficult to treat. So, we are eager to learn from you, sir.
Yes. Good afternoon. Well, this is a slightly different topic in the sense that we are not going to talk about the usual the endocrinology aspect of Graves' disease. Rather, it's a little different, and that's why it's known as nuances. The word nuances actually have got a multiple meaning. It can be gradation, subtlety, degree. So that way, it's a slightly different degree of the standard Graves' disease that we know is we are going to talk about for a few minutes. Graves, Robert James Graves, the renowned physician. The disease goes by his name, but we must also remember much ahead of Graves, Caleb Hillier Parry from the same country, England, in the year 1825 had described this disease in no uncertain terms, and followed by Karl Fedolf John Besdow, who had from Germany had also described it in a very clear fashion. So ideally, it should be called Parry-Graves-Besdow disease. Anyway, it goes by the name Graves' disease. And he was a very interesting personality, so to say. he in fact first gave a very clear account of something very close to what we now know as Guillain-Barré syndrome. He also described angioneurotic edema for the first time and called it a fugitive inflammation. So quite interesting. He was a polyglot. He knew many languages. And what is very important and very interesting to note that the watch that you use today has got a second hand. Though he had not invented it, it was invented by, so to say, another physician, John Floyer. He first described how we can use a second hand and we can understand how important it is in diagnosis of Graves' disease as well. Graves' disease, we know, it's a dysfunction of the thyroid gland leading to mostly thyrotoxicosis, and in a minority there is hypothyroidism as well. But it is also important to know that the importance of Graves' disease goes beyond that, and it can also affect some other structures like skin, where you know it's known as dermopathy, and different sort of affection of other organs leading to what we know as acropathy. So this dermopathy or pretibial myxedema, as we know, is not that common, but it is easy to diagnose, but very difficult to treat. The natural course of a pretibial myxedema, if in a published study it showed that it started only with small reddish plaque and then gradually evolved to an elephantiasis later on. And this happens basically because of various changes inside the dermis. The typical lesion is orange skin, pudy orange type involving the sheens, mostly sheens. Other sites are also affected, can be face, arm, shoulder, etc., etc. And the presentation can be a non-pitting edema, the classical one that we associated though with hypothyroidism, but it affects the sheen in hyperthyroidism, so to say. It can also be a plaque type, it can also be a nodular lesion, and in very rare situation it can also be an elephantiasis form as well. This happens primarily because there is excess deposition of glycosaminoglycans produced from the fibroblasts, as we see in thyroid orbitopathy. But if it happens in the skin, it becomes a dermopathy, where there is excess deposition of these glycosaminoglycans, leading to what is known as non-pitting edema. And there is also, because of this excess deposition of these glycosaminoglycans and collagen fibers, that obstructs the lymphatic flow, and that also contribute a lot to this elephantiasis or to this non-pitting edema as well. If we do a bit of an histopathology, we'll see there is mucinous substance which acquires blue color with alcyl blue stain. Obviously, it comes with a differential diagnosis. That's not the only reason you have got non-pitting edema. You can also have some other form of skin edema like lymphedema or lipodermatosclerosis. But fortunately, we can easily differentiate between them because so far as the location is concerned, the pretibial myxedema occurs mostly on the sheens or on the lower extremity. The edema is mostly non-pitting, while in lipodermatosclerosis is pitting. Redness is mild or sometimes absent even, whereas it is much more present in lymphedema or lipodermatosclerosis. Associated thyroid disease, probably the most important clinching factor, which gives away the diagnosis. In most of the situation, we will find that is associated thyroid dysfunction. Pathologically speaking, there is deposition of mucin, and in other situations it is not because of glycosaminoglycans or mucin or collagen fibers, it is because of something else. It can be paniculitis and full-fledged inflammation that is present. And also very important that this thyroid dermopathy or pretibial myxedema is actually painless, no pain, but in some situations of lipodermatosclerosis it is painful. So differentiating it from other situations is not difficult. But a very important question, why does it happen? Well, honestly speaking, even today we really are not very sure why actually it happens. But there is autoimmune mechanism perpetuated by the TSH receptor antibody, and which in close association with the IGF-1 receptor, the TSH receptor resides very close to the IGF-1 receptor in the orbital fibroblasts and also in the dermal substances. And when, because of the autoimmune process affects the TSH receptor antibody, it has got a crosstalk with the IGF-1 receptor, and this IGF-1 receptor causes the excess amount of fibrosis, excess amount of glycosaminoglycan deposition, excess amount of fibrosis and other issues that comes along with it. And that's the reason we see, like in the eyes, in the orbits, the pathology is very many similar in the sense that it is the orbital fibroblasts which has got the TSH receptor antibody coupled with co-localization of IGF receptor antibody. It stimulates the various other downstream pathway perpetuated by various other factors like IL-10, TGF-beta, interferon gamma, IL-1 beta, interferon 6, etc. And these in effect causes the skin and the orbit to change. Now that also gives us an opportunity to find the treatment for this one as well. Like if we think of that it affects the IGF-1 receptor antibody, then we can think of blocking that antibody with a monoclonal antibody which is available now in a commercial world known as teprotumumab, and that's the, so to say, the treatment modality of thyroid eye disease. We can also think of stopping the TNF-alpha by using infliximab or etanercept. We can think of changing the role of IL-6 by blocking it with tocilizumab. You have got option of SHR-1314, which is now known as vunakizumab, and another antibody which can block the IL-17A, and the K170, which is now sort of undergoing phase 1 trial, which is an TSH receptor antibody, monoclonal antibody. All these can change the scenario so far as the thyroid orbitopathy as well as the pretibial myxedema as well. So what are the current treatment options that are available? Traditionally, it is the topical and intralesional steroids, mostly clobetasol or some other form of steroids. You can also think of JAK-STAT signaling pathway pivotal for the T cell activation, and that's why you have got tofacitinib, which is a JAK1, JAK3 STAT inhibitor, has also been found to be quite useful. Case reports and series have been are there for teprotumumab, which is being used as thyroid orbitopathy treatment, is also useful just because of the similarity in the pathology in pretibial myxedema as well. Intralesional betamethasone is the standard modality of treatment that gives a significant degree of benefit unless and until it has gone into a stage of elephantiasis. Some reports are there like tofacitinib, which has also shown benefit, but only a handful of reports are there. Teprotumumab, like thyroid orbitopathy, has also been used and had shown benefit in only one patient as far as I can access the reports. Radioiodine treatment for thyroid orbitopathy or Graves' disease has given benefit not only in thyroid orbitopathy but also has given benefit for pretibial myxedema. But we must also remember that after radioiodine treatment, the thyroid receptor antibody level goes up. So it might worsen the situation of pretibial myxedema as well. It's possible. The other, the affection of the skin and bone by thyroid is thyroid acropathy, which once again is not very common. This probably is the extreme example that is seen, It presents with usually digital clubbing. And if you go for an radiography of that, we'll see that there is swelling of digits and toes, as you can see here. And there is formation of new bones in many of these situations. If we take a radiograph, we'll see there is periosteal new bone formation, mostly in the ulnar aspect, but also in some proximal phalanges as well. At times, it can be very fast, leading to a painful situation. Severe nail pain can be a presentation of thyroid acropathy. And it also comes in a differential diagnosis with a clubbing, the standard clubbing, the pulmonary osteoarthropathy. But it may not be very difficult to find out the differences. Usually in most of the situations of thyroid acropathy, there is thyroid orbitopathy and dermopathy present. Pain is rather quite rare, it's not very common, whereas pain can be there in clubbing associated with pulmonary disease. In most of the thyroid acropathy, it is symmetrical, whereas it may be asymmetrical in some clubbing associated with pulmonary disease. And obviously, TSH receptor antibody titer will be much higher in situation of thyroid acropathy, because that's the, so to say, prerequisite. In very unfortunate situation, there can be a conglomeration of both dermopathy and acropathy, as we can see in this particular situation. Else, it's usually an isolated dermopathy and isolated acropathy. I'll stop here, thanking you not only for your attention, but not heading to the lunchroom earlier than what is required. Thank you very much.
Thank you. Thank you, sir. As usual, an excellent presentation. And I believe the audience is more enthralled than us. So the floor is open for questions. So any questions from the audience?
Yes, please.
Thank you very much for your kind delivery. I have a different question. Often we come across patients, very rare ones, who after giving methimazole or carbimazole goes for severe rash within few days, skin rash. Do we switch over to propylthiouracil or go for radioiodine ablation?
I mean, both the options are okay. I mean, you can definitely think of going for propylthiouracil or radioiodine treatment. Probably radioiodine treatment would be a better option because there can be similar sort of rashes with propylthiouracil as well. So probably that's it. But having said so, we're also aware of the fact that in this city, the option of going for radioiodine treatment is limited, only restricted to some centers. And in most centers in private sector, unfortunately, they give a lower dosage, which makes the failure much more common than the success. Yes, please.
I have a comment on this question. If a patient presented with rash, if it is severe enough, then probably it is not a good idea to shift to PTU. Because it could be same type of lesion, appear with the PTU. But if it is a minor reaction, then you can continue methimazole or carbimazole along with antihistaminics. There will be no problem. But you should have a proper mind that patient probably we have to shift to radioiodine therapy, because patient may complain of similar type of rash when you will stop antihistaminics. So this is the most important point. I have an experience with the dermopathy. We did a series of tests and many things, but we did a study maybe 10 years back with dermatology department of IPGMER, where we found actually in clinically we do not see dermopathy often. But when we got a skin biopsy from the PTBL region, a handful of, it is approximately 20% of patients, yes, 20% of patients, they are actually presenting with subclinical dermopathy. So probably if we look properly the skin, and if we have in our intention that we may find some dermopathy, you can think of skin biopsies in that cases.
Yes.
But definitely this is an academic exercise. For practical purpose, if there is no problem, you should not do anything.
So any more questions from the floor? So I believe there is none.
Thank you very much.
Thank you, sir, for your excellent and lucid presentation. Please all give a big round of applause. So, coming to declaring the closure of your ceremony, so we will just utter the Sanskrit sloka. Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pasyantyu, ma kaschit duksham. So thank you all. So everyone stay well, everyone stay cured, everyone stay healthy, and may nobody be touched by the unholy touch of sorrow and unwellness. Thank you. Thank you. Thank you.